experts of secondary prevention. Kassim Javaid, he is a rheumatologist. He's an associate professor in metabolic bone disease, and he also comes from University of Oxford. He is a specialist in common and rare metabolic bone diseases, and he is leading the Oxford Fracture Prevention Service, which I think is one of the first FLS services.
Oh, that's not true.
It's not true.
So I'm very humble. I learned
But
from other people.
You were quite early.
I was quite early, yeah,
Yeah,
but we weren't
yeah.
the first.
So you are going to talk about FLS and how to get it started.
Yep.
And how to then give the patients a good secondary prevention.
Thank you so much. And I want to echo Matt's comment. Real great privilege to be opening the plenary session. And I'm so relieved. We've had animation, no slides, so this is going to be in the middle, the standard PowerPoint presentation. So you can relax, and I'll put the slides up. You can have them afterwards. So here are my disclosures. And it's quite difficult after working in the field for 15 years to compress it into 20 minutes. I wish I had Matt's focus thing, you know, just replace the metal or put cement in. So my purpose is just to give you ideas. You're all at different stages. Who here has an FLS? Okay. Who here wants an FLS? And who here has got an FLS but knows deep down that less than 80% of all the patients who should be on treatment are on treatment? Yeah, so I'm here for you guys as well. So wherever you're at, I'll say something and you think that's a good idea, just write it down. That's the purpose of this. Not to be comprehensive, but to stimulate thoughts that we can network later. So let's just get to a really basic overview of why I'm here. So we know that people break a bone after they fall. Some of them don't have osteoporosis, some of them do, and if you do nothing, they'll get worse and have worse fractures. And we now know there's an imminent risk of fracture in 2 years, so you have to move very fast. Maybe not hip attack fast, but pretty fast to get them onto treatment. And we call that treatment paradigm model an FLS. And an FLS has evolved over time. When Alistair McClellan and Stephen Gallagher first did an FLS, it was a one-stop hit. You went in, saw the FLS, and out you went as quick as possible. And we've now developed into a 5-stage model from identification, do the assessment, recommend really good treatments, monitor them to make sure they are starting the treatments first of all, and then staying on the treatments, and then build in that service improvement. And FLS isn't about every single fracture patient. It's not about the one with renal failure, it's got multiple fractures, very complicated comorbidity. It's for 80 to 90% of your people who've just fallen over, had a fracture, they've got osteoporosis, they need to get onto the best treatment possible. And we had a great start. So the pioneers really opened up our eyes. So Alistair McClellan, fundamental shift. Osteoporosis clinics shouldn't be in the rheumatology department, they should be in Matt and Julie's department, where they're coming in with the end point. That's a big shift. Then we had Rick Dell with a sort of systematic implementation through a health organization in the States, and Marcus Ebel's work in Australia, where they put it into Australia. But all of these pioneers really drove it through basic dogged, they just kept going. They were going to get it done, whatever, it didn't really matter. But as we've evolved our international experience, the first step to getting started is getting the policy right. If you don't have the policy right, your energy as a pioneer will run out when you retire, and then there'll be no one left to lift it up. So unless you have the policy change, you're not really going to have that sustainable secondary fracture prevention. And we're really lucky. Policymakers love secondary prevention. They love it. They do it for heart attack. Over 95% of people after a heart attack get secondary prevention. And if they knew what we knew about fractures, they wouldn't understand why they let anyone in their hospital go without having a bone check when we know the refracture risk is so high. And there are a couple of levers you have now in this decade because the UN has supported the decade of healthy aging. And we fit really nicely into a number of these imperatives. So if you're looking for that policy lever, how can I get the attention at the national, regional level, look up the UN Decade of Aging. Because when you do some very simple maths, it's a little bit troubling. From 2020 to 2015, the number of over 50-year-olds will go up by 70%. So if you think your trauma units, your rehab units are busy now, it's going to get even busier, and that is not distributed evenly. It's really going to hit Latin America and Asia the hardest. And the UN Decade of Aging has a very important pivot point. Forget about treating aging as a disease. It's an opportunity to improve social participation. And if you have a fracture and you can't move, you cannot participate in social activities. So we fit into that really well. And we have an issue with our community and the policymakers, because when they think of aging diseases, they think of these diseases. And we need to push this at the national level, because we've known for ages that osteoporosis is a classic age-related disease. It goes up with aging. And we also know that there is widespread bone health ageism. So in the UK, we have this sign saying old people are old people because they have a kyphosis. And that's osteoporosis. So we've normalized having the disease. And all of these issues are barriers we have to really address head on if we're going to get onto that platform of being including in aging diseases. And one way, and I'm going to use the example from Japan, is you have to make visible what it means to have osteoporosis in your country. So Japan, 120 million people, 200,000 hip fractures a year. What does that mean? 44,000 people every year with delirium. You think of delirium on one patient on your ward as bad, imagine 44,000 of them. Look at the bed days. Look at the admissions to long-term care. These are numbers that would really motivate a policymaker to take your disease specialty as specifically important. And some data from the UK. After COVID, we ran out of beds. During COVID, we had no beds anyway, but after COVID, we ran out of beds, and we can't get the waiting list down. So how do we get the waiting list down? We have to create the space for all the catch-up operations. So why do people go into hospital after emergency admission? Number one cause is pneumonia. Number two cause in England and Wales is hip fracture. And we have to change the nomenclature. So it doesn't say hip fracture, it says osteoporosis. And we have to say to our policymakers, this is what it's costing your country, and we have to get this data for our hospital. So in our hospital, we can go to our person and say, you want to get more people in for elective arthroplasties or whatever you want to do. Actually, the number two cause for people coming to hospital you can't control are hip fractures. And then we have to communicate in a way that Matt's done. I can put tables and slides up, but policymakers don't really want to hear that. They want to hear things that they want to hear. And so this is some work we did in 2019 with the Global Coalition of Aging, with IOF, and the Japanese Osteoporosis Society. It was an amazing roundtable discussion. Julie, there were no slides. It was just 3 minutes, each person had to pitch. And we had the Minister of Finance, because they have to pay for it, the Ministry of Economy, how do you actually use FLS to improve the healthcare industry? Minister of Health, how does it reduce healthcare burden? And the Minister from Research, how can we improve our research? And I was bringing all these people together. They said, this is what we need, and they gave us a checklist. And what they really wanted was this graph. How do you put FLS on the map with everything else they're worried about in policymakers? So on the x-axis is why do people go into long-term care? Dimension number one, then it's stroke. Number three is fractures. That's a big burden. And then you do something very simple. You go into PubMed, systematic review, second prevention, hospital admission. How well can you prevent a hospital admission after the index event? Dementia, really hard. Blood pressure and stroke, fantastic. You should do that, it's really, really good. But look at how impressive fractures are. It's really up there in terms of a priority for our policymakers. And this, contributing with the excellent work from the Japanese Osteoporosis Society, led to what I think is the best international example of policy for supporting FLS. I accept this after hip fracture, but they've separated out the reimbursement for the hospital cost, rehabilitation cost, and there's a community reimbursement for 1 year if they meet certain standards. And that's really joint-up thinking, understanding that hip fracture care isn't the hospital, isn't the rehab, it's the entire journey up to a year. And they have opportunities now with their data. We're looking forward to see how they're going to handle the rehab, how can they get the reimbursement secured, what about the other fractures, and how can this end up showing leadership internationally. I'm going to walk through some other countries and their experience and highlight some similarities and also some challenges. So the next one is Republic of Ireland. The government pays for a database to check how all hospitals do. They've just released their second report, very fantastic reading. They've managed to increase their engagement more than we ever did in England, really good. And what they've showed is some indicators get better and some indicators get worse. And this is fantastic news. The country can now have a data-driven approach to improving FLS. They know what's getting worse that needs attention. They know what's improving, they can take the pressure off. And that's one of the beauties of having a database. And their opportunities are they've got the database and nurses funding. They're not funding any physician or surgical time, and they're not funding any administrators, which is kind of interesting. Wales has done something that many countries have done. They've actually said, we want an FLS, but we're not going to give any more money for it. It has to come within existing budgets. And I still think that's a very positive statement. Because if you want to set up an FLS in a country that's got that, you can then go to your hospital and say, well, actually, the health minister says you need to have this. Can we talk about how we can reprioritize the funding to divert more money to FLS? So even though you might think, oh, that's really bad, we need more resources and nurses, it's opening the door for you to come in with that evidence to maybe prioritize you against other systems. And then on the national level, we've got this Liaison program from the Netherlands, really important document, more of a policy document, again, no funding, but it opens the door. It highlights two areas: improved diagnosis, so make sure all your fracture patients are being assessed, and then make sure as many of your fracture patients are being treated. And this again opens the door because in the Netherlands they have very regional delivery of care, and now it's up to the regional team to take that national directive and use that to push regional delivery. And there are lots of other examples could go on, but do go and see what Paul Mitchell's been doing in New Zealand, really transformative, working with the AAC. He's got second-year funding, and it's really how you can take a whole system approach. And of course, the work that we've been doing with the Royal Osteoporosis Society and actually developing tools and implementation guides for FLS. So that's the national experience, but what have we actually achieved with that? So Capture the Fracture map is the best way to look at this. If you haven't been there before, it's great, get mapped. Over 800 FLSs across 55 countries at different standards. We never actually look at this critically. It's great, 800 FLSs. What does that mean? Well, only 97 are scoring gold, and some of those scored gold more than 5 years ago, so we're not quite sure how up to date they are. And everyone says gold is aspirational. But when you look at gold, gold means you're actually treating all the patients who should be on treatment, leaving no one behind. So if you're not achieving gold, what you're effectively doing in your fracture clinic are saying, actually, you, and you, I'm not going to have the capacity to see, and if you've got osteoporosis, you're on your own, maybe your GP will help you, but you're maybe going to get worse and fracture again. So we need to make that less acceptable. We need to put in FLSs that see all the patients need treated. It's not fair to leave them out because they've got dementia, they've fractured on treatment, maybe you don't have monitoring, or maybe you're not offering the right treatment. And the right treatment is very important for FLSs. Of course, there's falls interventions, but we've now had a revolution in our anti-osteoporosis medications. We now have access, some of us in the world have access to very potent anabolic treatments that have transformed the way we are now treating FLS patients by using these drugs first line. Because when the health economists get hold of how much fractures go down and see you put on more bone in 1 year than you do in 5 years at the spine or 3 years at the hip, that really reduces fractures quick enough for it to be of benefit to the FLS. And you can do some economic modeling, and what you can show is actually how bad oral alendronate is. And that's one of my sort of challenges, is to actually try and get us to move away from oral alendronate if it's affordable. If it's not affordable, oral alendronate, great drug. But be aware, because of the rapid recurrence of fracture within 2 years, how long it takes drugs to work, and how strong those drugs are, if you look at what happens to patients after they've had a fracture, maybe of the humerus, they're age 75, they've got a T-score of minus 2.9, over 80% of the refractures will still happen if you give them alendronate. That isn't a great treatment for reducing fracture risk if 80% of the events still happen. So we really need to take this on board. So when we think about FLS, we're also thinking about the whole pathway. But there's a broader issue of how we get there. It's really hard to find out how many hospitals there are in the world. No one really knows. But they've done a study, hospitals per million people, they picked 31 countries. And in 31 countries, there's 25,000 hospitals. So even if all of the capital fracture map FLSs came from those 31 countries, which they don't, that's only 3% of hospitals having FLS coverage, which means 97% of hospitals have got nothing, not even a blue star. And I think that's our fault as metabolic bone experts. Who here would say they're a metabolic bone expert? See, that's the problem. How many hands went up? Because what tended to happen is we would say we know everything about osteoblasts and osteoclasts, we know how to write the pathways, let's work with our orthopedic colleagues and just pull the patients from orthopedics and geriatrics into our sort of bone world. But there just aren't enough of us. There are very few people who would say they're bone experts or have that level of expertise. And actually what we need to do is a new paradigm. We need to recognize that for the bone expertise you need for FLS actually is completely within orthopedics and geriatrics. It doesn't need much additional training. Of course, the complicated patient, and orthopedic surgeons love talking about AFF. I was talking to the team last night about AFF, and AFF with arthroplasty is really complicated. But that you can leave that to the specialists and whatever they want to do. But actually, for a foundation FLS, that should be within routine care in orthopedics and orthogeriatrics. And Frida, our chair, is already doing that. And there are loads of examples where we haven't delegated bone health care to the bone experts. We've said, actually, how hard is it to find them, assess them? If there's a treatment pathway, we'll just follow it. And we just have to make sure we have the right patient support so that when the patients ask questions, we can answer them. And you can almost see that we've moved from this sort of innovation, diffusion of innovation from wheat growers from America. Fascinating history. But pioneers are the crazy people at the beginning. The Alistair McClellan, the Rick Dells, they just said, let's just do it. And then the early adopters like me said, well, you can do it, but let's just make it easier to do by developing tools. It's not just one person, let's try and do that. And we're now at an amazing time in the history of FLS. Now we need to hand it over. We've developed the tools, we know how to do it. Now let's just normalize it. So anyone who can do it, just pick it up, we'll support you, but become the majority and just deliver and implement your FLS. So the timer here isn't working, so I'm still at 0 minutes, which is fantastic. I've got 25, but I'll be very quick now. So things to look out for. Resources are the issue. You have to make a compelling plan to whoever decides to fund your FLS. You need to understand the economics. Very few of us are health economists. Very few of us even understand what they need to know and language they need to do. So there are tools out there. This is the tool Rafa Pineda Villanueva, an amazing health economist from Oxford, developed, and it maps out the benefit from FLS in a way you can understand. So it says, what happens if you do nothing? What happens if you put FLS in? How many fractures do you avoid? What does that mean to the hospital? What does that mean to the budget? And what does that mean in terms of the size of your FLS? What we know very little about is the benefit beyond health. Treasury doesn't really care about health. They care about taxes and benefits. We don't know how many people, because of their going through an FLS, actually have to change job, lose their job, or actually someone in their family has to lose their job to look after them. We haven't really defined the bone health beyond health. What about insurances? Why are they paying for people to go to orthopedics again and again because of a fracture? It seems a little bit unclear. And we're pulling people to work longer in the silver economy, but if they're having fractures, they're not going to be able to deliver that economic aim for the country. So the Treasurer needs to know that if he wants a fit elder workforce, he needs to sort out their fallen bones health. And then COVID was disaster for the world, but offered opportunities for telemedicine. I think we've broken this. We don't need one FLS per hospital. We've got telemed, telephone calls. You can have one FLS covering one region. You can have one clinical lead for lots of FLSs. And it's this joint-up thinking, I think, is going to really transform our innovation. And working with teams across the world, we've now developed checklists. So how do you get an FLS started? And there's a really simple process for doing this, and also becoming more effective. Becoming more effective is actually a very challenging thing, because to become more effective, you have to see fewer patients to measure what you do better. And most people don't like seeing fewer patients, but it's worth it in the end, because the quality improvement is very big. And the reason I'm so confident about that is because we've now brought in tools from other disciplines. So fishbone diagrams are like a very unusual word, came from Japan, but actually we are now taking tools from other industries to make sure if you do want to improve your FLS, we can make sure every minute you spend doing that is the most effective use of your time so you can improve your services as quickly as possible. Finally, digital. There aren't enough people in the world to run all the FLSs if 30% of their time is spent doing repetitive administrative tasks. So we just need to address that problem. You shouldn't have an FLS unless it's a digital FLS. There should be a computer system that takes all the effort out of identifying the patients, assessing them, making sure they're templated, sending out the recommendations, reminding you of monitoring, and getting your database. They seem to be seen as the cherry on the top. I now think it's actually the sponge of the cake. Unless you have that digital in, your nurses are going to be, your administrators are going to be really tired, your physios, your DEXA technicians. And by doing this digital approach first, you make sure your FLS is more sustainable. But digital goes beyond that. We've all heard of AI, and AI is going to transform how FLSs find vertebral fractures maybe. So in our hospital, there are over 1,000 CTs every month for people who have over 50 that include the spine. And we've now used an AI program that looks at the scan. Out of the 1,000 scans, it finds who's got the fracture, a clinician confirms it, and that patient, without ever touching orthopedics or trauma or any other healthcare system for spine fractures, is now a spine fracture patient in the FLS pathway. And we've worked out the patient communication and the patient reassurance from that. It's called the ADOPT study, and the preliminary results is the AI is incredibly flexible. If you just say, look, I don't have time to check if the AI is right or not, you can set it so the AI only finds people where it's pretty sure that you've got a fracture. Nearly everyone it selects has got a fracture. If you say, no, actually, I want all the fractures, and I'll let my radiologists or my nurses or my specialists sweat over seeing who does or doesn't have a fracture, you can go for ones that have got very high sensitivity. One question we had from lots of people was, Kassim, what are you doing? These people have had a CT scan for a bad thing, and you found a vertebral fracture. Will they live long enough to actually benefit? And they do. So this is their survival 6 months, 1 year, 2 years, and 5 years after a vertebral fracture identified using routine radiology CT scanning. And it's different. So it looks like, and this is preliminary data, if you have a CTPA and you're a man, you do really badly. They may be a group that don't do very well, but everyone else seems to be surviving long enough for FLS to benefit. And then finally, we've got the database. So this is what I've been working on. It's really a credit to David Marsh, there he is, at the front, who came to me and said, I've got the hip fracture database, but how do we stop them getting into the hip fracture database? And this is what's being used in Northern Ireland and New Zealand and will be used in Japan. It's a publicly facing output of how well you're doing. And this will transform your vision for FLS in your country. You've got all the hospitals as rows, you've got all the key performance indicators, how well you're doing, and you can see where you need to learn from others and where you need to actually have a national program. But at the FLS level, it's an indispensable resource. So here you've got how many people are getting a falls assessment. Dotted line national average, solid line what we're doing. And you can see when the new nurses started, we forgot to update the induction plan. And if I hadn't had the FLS DB, those new nurses would not be doing a proper falls assessment. And it's only through this passive collection of the entire pathway you can spot differences very quickly and improve care. And my final tip is don't do what we've done in the UK. Hip fracture database, FLS database. After 10 years, it's my biggest headache of trying to merge them. If you haven't got one, just set up one system. Just set up a fracture registry. If the person ticks hip fracture, they get some more questions. If they don't tick hip fracture, they still get the same secondary fracture prevention and falls care. It's a much easier way and more sustainable and ultimately cheaper way of doing it. So I've thrown you loads of ideas. How do you actually use them? Well, work together. Form a community of mentors and make this a stepwise approach. We've done this with the IOF, and we're doing this with the Fragile FLS Academy Network. You set up a global network of experts, and they help deliver the care. What's the evidence that this sort of mentorship activity works? So this is some work that we've just got published, and I put the co-authors up there especially because those are all the mentors that helped us, and some of them in the audience, and I wouldn't be here without their work. So the table shows their confidence in quality improvement and being a mentor before and after the program. You can train people to do quality improvement and be confident about it. It's not difficult, it just takes time. And more startling is the impact on the number of FLSs that are mapped. And you can see the increase across Argentina, Brazil, Colombia, and Mexico, and they all start at different times. Chile did not have access to the program, so they're our control country. So you can actually see mentorship does make a difference. You do increase FLS implementation, and working together makes a difference. But you don't have to do it on the big scale. This is some work I'm doing with a city in Germany. It's a one-on-one, and what we're doing, we're taking them through this sort of process for developing an FLS, and you can do it on the small scale. Don't think you have to have a huge program behind you. A very targeted, supported program can also achieve. So these are my 5 take-homes. If I had to limit this, list is 20 long. What are the 5? Work out your impact in your country. If you don't know how it impacts your country, you will not make the policy argument. Think about the delivery within the existing pathway rather than adding in a bone expert program. Understand the training needs and the digital needs for your service. Embed data-driven service improvement. It is really complicated because people leave hospital, you have virtual clinics, adherence is funny in primary care, you need a system for doing it. And then work together as regional networks. I work as a small cog in a huge team. I want to thank everyone, especially FSDB, and I'll leave my final summary. Thank you very much. Thank you so much.